Hello, everyone, and welcome to the first activity of our special series, Evolving Treatment Targets and Monitoring Strategies in Crohn's Disease. I'm Dr. Aline Charabaty, Associate Professor of Medicine at Johns Hopkins School of Medicine and Medical Director of the Division of Gastroenterology and Hepatology and Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital in Washington, D.C. I'm joined today by my colleague and friend, Dr. Jami Kinnucan. She is a Senior Associate Consultant in the Division of Gastroenterology and Hepatology at Mayo Clinic, Florida. She's also the GI Practice Chair of the division and the Director of the Intestinal Ultrasound Program in, again, Mayo Clinic at Jacksonville, Florida. Jami, welcome, and thank you for being here.
Hey, Aline, thanks for having me.
Over the next few weeks, we will have different activities, such as short webinars like this one, tutorial, clinical vignette discussion, all focused around treatment strategies and target in Crohn's disease. All these activities are CME certified and jointly provided by PACE and Bonum CE, and these activities are supported with an educational grant from Lilly. Our disclosure are here on the screen. And if you haven't already completed our pre-activity survey, please do so by clicking the link below this video or by scanning the QR code shown here. Let us know who you are, and don't forget to complete your evaluation at the end of the session and claim your CME credits. And of course, please follow our platform, Monday Night IBD and Bonum CE, and set your alert notification for more CME certified programs. So, Jami, today we're going to review together the current treatment goals in Crohn's disease and the evidence supporting the treat-to-target approach in the management of Crohn's disease and best practices for implementing this approach in our clinic. As we often do, our choices of therapy for a particular patient with Crohn's disease depends on how the patient is doing today, their disease activity, but also on their risk of disease progression over time. Are they going to develop complication like fistulas or stricturing disease? Will they require hospitalization and surgery? So, Jami, can you start us off by discussing how we can recognize which patient with Crohn's disease is at higher risk of disease progression over time?
Sure, happy to. And really talking about the importance of how do we individualize our approach to patients with Crohn's disease is how we risk stratify those patients. What clinical characteristics do they have? Disease behavior criteria do they have that is associated with what we know has been shown to progress disease and worse disease outcomes? You can see here, we really dichotomize into those patients that are lower risk and those patients that are higher risk, but it's not always so clear. And sometimes there's a variation between them. Those patients that are at the lowest risk for disease progression are those that are older in age at diagnosis, that clearly have a limited extent of involvement. Those patients that we see in our practice that are very isolated, limited disease, no evidence of perianal disease or rectal disease, no stricturing or penetrating behavior to the disease, very superficial erosions, and those that have not required surgery for those diseases. Those kind of patients are very clear cut in our practice. But then there's the patients that are at higher risk for disease complications the longer that they have disease. So we know that younger patients, male patients, those with more extensive anatomic involvement, those patients with isolated ileal disease and upper GI Crohn's disease, those patients that have perianal disease or have rectal disease or rectal ulcerations, a very rare phenotype that we see in Crohn's disease, or those that have risk factors for perianal disease. Stricturing or penetrating phenotype of disease is those patients that are already developing complications, those that have had multiple resections or even a single prior resection. And we also know that some of the modifiable risk factors are around smoking, and those patients who are actively smoking, we know have worse disease outcomes. So this slide is really helpful to kind of understand which category those patients fit into. But in addition to assessing those for risk for disease progression, it is also important to define disease severity. Aline, can you help us understand how you're doing this in your practice?
So when we're assessing the disease activity in a patient, I look at the clinical symptom and the endoscopy findings, as well as the imaging finding if we are looking at a patient with small bowel Crohn's disease. Clinical symptom, of course, the classic GI symptoms, abdominal pain, diarrhea, urgency, but also look for symptoms for potentially stricturing disease, like abdominal distension, vomiting after eating, a slow weight loss. I'm also looking at how these symptoms are affecting the patient overall health and quality of life. Are they able to eat the food they enjoy? Are they able to do their daily activity, maintain a job? Are they on disability? And also looking at any extraintestinal manifestation of the disease that the patient may have. In terms of endoscopy, I like to use the SES Crohn's disease scoring system. It assigns a point to each of these features that look at the disease activity and its extent. How many segments of the bowel are involved with the disease? What is the percentage of each of these segments affected by ulcer? The size of the ulcer, small after swans or deep large ulcers, and the presence of stricturing disease. And of course, you can use the imaging to assess small bowel disease and perianal disease. So to summarize, when you are deciding on a treatment for a patient, we're looking at the disease activity now, the risk of disease progression. Jami, do we have any decision tools or blood tests that can guide clinician in our choice of therapy?
In my practice, I've been using a lot of the IBD clinical decision support tool, or IBD CDST. This is a support tool that's a web-based tool. A lot of the work that was done by our colleague, Dr. Bear out of Northwestern. This is endorsed by the AGA, and it's actually an excellent tool for two reasons. So all those risk factors that I told you about before within that slide that has the arrows, this actually takes some of those as a clickable tool that you can use real time with your patient in front of you. And it spits out this clinical decision based on whether they're low risk or high risk for disease progression. So the patient can see that real time as you input their data. But in addition, this clinical decision support tool goes beyond that. It actually takes some of the data from the patient and helps you understand what their likelihood of response is to various therapies. And they're continuing to add on to this tool right now. There's several therapies that it'll look at what their likelihood of response is to vedolizumab, or what their likelihood of response is to some of our anti-interleukin therapies. But that's one of the tools that I'm using real time in practice with my patients. There's also another tool that you can use in a more newly diagnosed patient. So a patient that has had disease less than 8 years and has not yet developed complications. This comes from work from Dr. Corey Siegel out of Dartmouth. And this is actually a blood test that's done. It's supported by our colleagues at Takeda, and then it's actually run through our colleagues at Prometheus. And so this actually uses both biomarker data as well as genetics data to be able to identify whether or not patients are low risk, medium risk, or high risk for disease complications in the next 3 years. So by utilizing this clinical decision support tool and then augmenting it in a newly diagnosed patient with CD path testing, we're able to have that conversation that feels more individualized and personalized to that patient sitting in front of us.
That's phenomenal. So we have all these tools, all these factors to take into account to choose the right therapy for the right patient. So let's switch gear now and talk about our treatment goals. When we talk about treat to target, what does it actually mean? And what are the different targets that we want to achieve with our treatment in patients with Crohn's disease?
Of course. And that's the reason why we do all of this, right? We have to initially understand what's happening with our patient right now. We have to define what their baseline disease activity is. And then we have to discuss, well, where do we want to go? What are those targets that we're looking for? As you had discussed, clinical symptoms, right? We want to make our patients feel better. So we have various clinical symptom scoring tools. We have patient-reported outcome tools, and we have validated clinical indices that can be built right into your electronic health record to help you understand what that patient's baseline is, and then to follow them over time after starting and initiating treatment. But we know that we need to go beyond just clinical symptom improvement and or resolution. We really need to look at objective markers for inflammation. You touched on some of those things around imaging and endoscopy and even histology, but there are biomarkers that we use in patients. C-reactive protein and fecal calprotectin are some of the common ones that I'm using in my practice, as well as imaging modalities like intestinal ultrasound to understand how patients are objectively improving from a disease activity standpoint. Combining these targets as a strategy overall has been associated with improved patient outcomes. So we apply this target strategy, so defining what those targets are, to the STRIDE-2 guidance, as they define targets based on the following criteria in your practice. We should be looking at short-term targets, which is really looking at symptomatic response after we initiate a treatment plan. Intermediate targets, which is looking at symptomatic remission and normalization of C-reactive protein in those patients that make C-reactive protein at baseline, really highlighting the importance of getting that baseline assessment so that you know where you started and then where you're going. Also, in this intermediate target is the decrease in fecal calprotectin. And then it goes on to look at more long-term targets. So after you've reached some of those short-term and intermediate-term targets, then it's when do you invite patients back to do endoscopic assessment to look for endoscopic healing, as well as improving or normalizing quality of life and absence of disability for our patients. So really going beyond just some of the endoscopic assessment that we do, but seeing the impact of disease on patient outcomes and how they're doing on a day-to-day basis.
So I want to switch gear to the SPIRIT data or guidance. Like you mentioned, we want objective markers of remission, the biomarkers, what we see on endoscopy, maybe transmural healing for Crohn's disease in the future. But we are also caring for patients, not just their GI tract, and we're treating a disease that affects patients in every aspect of their life. So how does the SPIRIT guidance give us more insight into what our goals of care should be in patients with Crohn's disease?
We all know that we can reach these targets, but patients can still have impact of their disease on their quality of life. So it's really thinking outside of just improving symptoms or resolving symptoms and checking boxes around CRP, fecal calprotectin, intestinal ultrasound, and endoscopy. But this SPIRIT guidance really goes beyond that and looks at the impact these symptoms can have on patients' overall health. So this ultimate therapeutic goal is really to decrease the disease impact on a patient's life, their overall life and quality of life. And then it looks at sort of the impact that that has on both midterm complications. So when we improve disease activity, we improve overall bowel damage, need for surgery or hospitalization. And then when we look at some of those long-term complications that we're wanting to prevent by getting that treat to target approach in practice, is some of those gastrointestinal and extraintestinal manifestations of disease or complications like dysplasia, cancer, and of course, in the rare situations, mortality to our patients. So really, it's taking that treat to target approach and then looking how it impacts these complications that we see in patients that haven't necessarily been monitored under a treat to target strategy. So between STRIDE and SPIRIT, we've discussed these short-term and long-term targets in treating patients with Crohn's disease. Aline, can you help review some of the data that came out from the CALM study that really highlights some of this benefit of treat to target strategy in our patients?
Yeah, absolutely. The COM study really highlighted the benefit of a treat to target strategy when treating patients with Crohn's disease. And if you recall, with the COM study, they looked at bio-naive Crohn's patients and they assigned them to a tight control group or clinical management group. At the beginning, all patients received induction therapy with adalimumab, followed by the standard maintenance of adalimumab every 2 weeks. But then treatment was escalated to adalimumab weekly, or if needed, adalimumab weekly plus a thiopurine, based on different criteria of treatment failure, depending on which group you're assigned to. So treatment failure in the clinical management group was defined as GI symptoms or needing a prednisone to control a flare. Treatment failure in the tight control group was defined with the same criteria, but also if the patient had elevated CRP above 5 milligram per liter or elevated fecal calprotectin more than 250, therapy was escalated even if the patient remained asymptomatic from a Crohn's disease standpoint. And what we see in the CALM trial is that a significantly higher proportion of patients in the tight control group achieved the primary endpoint, which was mucosal healing at the end of a year. Also, a higher proportion of patients in the tight control group achieved steroid-free remission at any point in time during that year. In addition, this tight control group had less hospitalization, longer period of remission, and improved quality of life. And overall, it looked like this strategy of treat to target, tight control, tight monitoring was the most cost-effective therapy in terms of achieving endoscopic and mucosal healing in this patient population and preventing steroid use and hospitalization. Now, this study had a follow-up, which is even more exciting. And in that follow-up, the researcher looked at all patients who achieved endoscopic and mucosal healing at the end of 1 year, whichever group you belong to. These patients who achieved endoscopic and mucosal healing actually had a better outcome over the next 3 years compared to those who did not achieve this endpoint. What I mean by that is once you get a patient in deep remission on your therapy at the end of 1 year, you can tell this patient that at lower risk of developing flare, hospitalization, requiring surgery over the next 3 years of their journey. So the CALM study is very exciting in many ways, really highlighting that a treat to target and tight monitoring of the disease is important to achieve our goal of endoscopic healing, but also it showed that achieving endoscopic remission, mucosal healing has an impact on the disease progression over the next several years. So we talked about research, we talked about STRIDE and CALM and SPIRIT guidance. Jami, I want you to give us a sense of how do you translate this research, these guidelines into your clinical practice?
Yeah, that's great. And we've said a lot of acronyms, but in reality, we have to put these into practice, like you said. So we have to really understand who that patient is in front of us. So we've already established what their baseline disease activity is, severity of disease, using some of the tools that you had talked about previously. In addition, we need to understand what at-risk features does that patient have, whether we use the clinical decision support tool and we augment it with blood testing, or we use just the clinical decision support tool alone. And then we have to partner with our patient. They need to understand where they're at now, and then where are we looking to go and what targets are most important to them. Educating them about the importance of the data that came out of the CALM study, not just about symptomatic improvement or remission, but reaching further than that. And then once we initiate a treatment plan, whatever that looks like, we have to have a plan to follow up. When are we going to check back in with that patient, either by a questionnaire in the next maybe 4 weeks? Are we going to do a repeat C-reactive protein or fecal calprotectin? And some of this stuff is really dependent on what therapy plan we select. And then if we aren't reaching those targets, we're not improving, we're staying fairly still or getting worse, when do we need to optimize our treatment approach? Or do we need to give it more time? And we need to plan to continue to assess that patient's progress on this treat to target journey until we've reached the targets that we've set forth. The challenge is that different treatments may take different amounts of time to achieve different target endpoints. And we've known that from some of the studies. We know steroids can act very quickly, and some of the more recent studies have shown that JAK inhibitors are very fast acting, as well as some of our other therapies. But maybe budesonide and some of our anti-TNFs and maybe our anti-interleukin therapies may take a little bit longer. And maybe if we look too soon, we may be thinking that we're missing the target, but we just needed more time. And it's very well known that thiopurines and methotrexate and at times in certain patients, vedolizumab can take the longest period of time to be able to achieve those targets. So we just want to make sure that we're individualizing that treat to target strategy based on the treatment plan that we had selected.
This is fantastic, Jami. Thank you so much for this very insightful review of the current data and guidance on treatment goals in Crohn's disease and how to monitor our patients. I think the key messages I'm taking home today from our discussion are, when we're choosing a therapy for a patient with Crohn's disease, we need to assess the current disease activity by clinical symptom and endoscopic finding, identify factors that put the patient at higher risk of disease progression. And truly what you've been highlighting is partner with the patient to define treatment goals that are both objective, biomarkers, endoscopy, imaging, etc. So objective markers of disease remission, but also really define with the patient what their goals of care are. And often we hear, being able to travel or enjoy my retirement. So all kind of patient goals that are important to take into account, and then choose a therapy that is the right therapy to achieve these goals. And then you highlighted how important it is in practice to monitor the patient throughout their journey to reassess their disease activity and adjust treatment accordingly, but also to know when to reassess disease activity once you initiate a treatment. And some treatment work faster than others. So it's important to effectively monitor treatment response at the proper time, and then decide if a treatment needs to be given more time, escalated, or switch to a different mechanism of action. But the idea here is find the right effective therapy for your patient with Crohn's disease early after diagnosis, monitor disease activity regularly, using objective marker, adjust therapy, and then to be able to achieve endoscopic and mucosal healing and allow the patient to achieve their own goals for their treatment with Crohn's disease. So thank you again for joining me today. Thank you everyone for listening or watching. Please complete the post-activity polls in the tweets below or by using the QR code shown on the screen. And don't forget to claim your free CME credits. Click like and follow for more social media-based CME from Bone MCE and Monday Night IBD.